afternoon, everybody. My name is Barbara Rosenberg. I'm with ElderWorks Educational Services. We're happy you're here at our wonderful day today. Thank you so much. I'm a senior advisor, helping seniors for over 37 years move to senior living and come up with wonderful resources like a Dr. Kahan for any of your questions, gynecologically, anything else going on. So I'm very, very privileged to introduce Dr. Randall Kahan, who was born and raised in Chicago. He attended the University of Illinois, for his undergraduate studies, followed by University of Illinois Medical School. Dr. Kahan is president and CEO of WomanCare and the director of pelvic floor and bladder program at NCH Women's Center. He brings to the program an expertise in treating female urinary incontinence, pelvic organ prolapse, and pelvic reconstructive surgery, biofeedback therapy, urodynamic testing, and minimally invasive outpatient surgery, and all modalities that have contributed to his extremely high success rate and ultimate patient satisfaction. Dr. Kahan performs minimally invasive outpatient surgery both in the office and hospital settings. Dr. Kahan is a certified robotic surgeon who has a very high volume surgical practice for all types of gynecological issues. Dr. Kahan is married and is a father of two, including a daughter in his practice, which is amazing. And so without further ado, Bladder, what's the matter? Dr. Randy Kahan. It's a great name. Thanks for being here.
Good afternoon, ladies. So Bladder, what's the matter? I titled this talk because I want to try to make light of an issue that plagues so many women, as they're getting older. And, I'm not going to make light of the problem, but I'm going to kind of try to break it down to you so that you understand some of the nuances of what this problem is. And I want to try to break some of the notions that a lot of people have that are truly misconceptions about what is normal, what is a normal part of aging, what are things you have to live with, and what are things that you absolutely do not have to live with. And, just in my background is that, I started becoming interested in this issue back when I was a young doctor in the 90s, because it seemed to me that there was just an aging population at that time. And this was a discussion that just never was had. People didn't bring it up. It was a taboo subject. And, there were women back then who are your age now who were just suffering needlessly. And so my mission is to try to get the message out that, look, if you have this problem, number one, you're obviously not alone. And we're going to talk about some of the issues that people face as they get older with their bladders. And I'm going to try to really impress on you that even though it's not discussed among your friends or among your family or in your doctor's offices, this is a problem that's rampant in your age group. And it really needs to be brought to the surface. So it's something that's okay to discuss. We're going to leave some time for questions and answers. And I would press on you to try to, not be embarrassed. I mean, believe me, if you have a question, there's 5 other women in here that are just sitting there waiting for that question to be asked. Okay, so anyway, let's go ahead and start. Okay, so I start with this because for everyone in this room that has a bladder problem, this is the first thing that you look for when you walk into a place that you're not familiar with, whether it's a restaurant, it's a shopping mall, it's a store. First thing you do is look for that. In fact, I play a game with my wife sometimes if we're waiting at a restaurant because I'll watch people come into the restaurant and I'll say to her, that lady has bladder problem. I'm really proud of my mind. She's looking around, and then before she wants to give her name, she wants to know where that is. So my point is that I'm just bringing this out again how common this is. Okay, next slide. So keep going. So no. So just as a general information. Incontinence, meaning the unwanted loss of urine. 1 in 3 women over age 45, 1 in 2 women over age 65 experience some urine loss when they otherwise don't want to. Okay. It results in a loss of productivity for those of us that are still working. It results in 1 in 5 women discontinuing what they otherwise like to be doing. So in other words, there's activities that they don't do, there's places that they don't go, there's things that they don't continue doing just because they're afraid that they're going to have a problem. So like I said, almost 50% here will change their lifestyle because of their plan. And it's really, in most cases, it's absolutely unnecessary.
Could you speak a little louder?
Yes. I can. So the impressive thing here is that 50% of women discuss it with their physicians, and the other just don't bring it up. And I can tell you just from just my general GYN practice, even with women that I've known for 25, 30 years, I will say to them, so how's it going? Today happened today. Before I got here, I was in the office and I would say, so how's everything going? Great, no problems. No problems. And then as I'm doing my exam, I say, do you ever lose urine when you cough or sneeze or, oh yeah. It's unbelievable. Yeah, it's changing. I'm like, why didn't you tell me? Well, what are you going to do about it? It's part of getting older. Well, no, maybe it is, but there's things you can do about it. The point is, if you don't bring it up, then there's nothing you can do about it. Okay, so less than 20% actually seek treatment for this problem. And most of the time, it's not until it's so severe that they can't even, leave the house. So the message is get out in front of it. Next. All right, so I think that in order to try to understand your bladders, it's important to understand how the bladder is supposed to work. Okay, it sounds simple, but really it requires a whole network of activity to happen that have to happen in the right order and sequence. So I'm going to explain just briefly how the bladder is supposed to work, because that is a better way to understand why your problem where in the line that it might be disrupted. So the bladder is a bag. And the bladder is surrounded by a muscle. See this muscle here? That's called the detrusor muscle. That muscle is not under voluntary control. You cannot control it. It is controlled by nerves that feed it from the brain and the spinal cord. When that muscle contracts, it presses on the bladder, and then you are in control of your sphincter muscle. That's the muscle that you tighten. When you want to stop your urine in mid-flow, if you're going to hold it, it is the sphincter, and it's right here. And so if there's a problem with the sphincter, obviously you can't hold it. If there's a problem with this muscle, then it's always contracting. So we're going to go into that a little bit, but in order for the bladder to work properly, this muscle has to function and the sphincter has to function. Okay, next slide. Okay, so again here, you've got these two sphincter muscles that surround the urethra. The urethra is the tube that you urinate through, okay? Next slide. So when the bladder is full, okay, you get a note. Your brain is being told, like right now, okay, you have receptors in your bladder, and there are those of you that didn't go to the bathroom before you get into this talk. And you might be aware that there's urine in your bladder. Now, your brain knows that you're not sitting on a toilet, that you're actually sitting in a lecture. So it's telling this muscle, don't contract, allow filling to occur. And as the bladder fills, those messages increase in sequence and severity to the point where somebody at some point might decide, you know what, I can't make it for 40 minutes in this lecture. I'm going to run out of here and go to the bathroom. Okay. In which case, they'll go to the bathroom, they'll sit down on the toilet. And when they sit down on the toilet, the brain says, okay, now she's on the toilet, go ahead and squeeze. And then this muscle here will squeeze. You voluntarily let go of the sphincter here and you urinate. That's how it's supposed to work. Okay. So Bladder control means that you urinate only when you want to. Okay, but it goes beyond that because it's not just urinating when you want to, it's not being aware of your bladder. Your bladder function should be something that you don't think about until you want to go. Now, I know that's not true for most of the people here, that you're constantly thinking, well, I went to the bathroom 45 minutes ago, leaving the house now, I better go again. Right? Who does that? Show of hands. Okay, lots of you, and there's a lot of people that aren't telling the truth. Because I'm telling you, almost everyone does that. And that, if you get nothing else out of my message today, you cannot do that. Because that doesn't solve the problem, it potentiates the problem, makes it much worse. And I'll explain why, okay? So in order for bladder control to work, those muscles, there's pelvic floor muscles, they must support the bladder. The sphincter muscle, the one that you tighten when you want to stop your urine, that has to work properly. And the nerves that feed the muscle that causes your bladder to contract have to work properly as well. So all of those things have to work. And what our job is when we see a patient that has a problem is to first put her history, her physical exam, and then oftentimes the result of some testing that we do together and come up with a diagnosis that's particular to that person. Because I can tell you, this is not a one-stop shop. You don't just walk in and get a pill or a surgery. You have to individualize the treatment based on the all of those findings. And too many times people mention this to an internist who isn't a specialist in this, and they just throw them on a medication, whether it's appropriate or not. And when the medication doesn't work, they think, oh, nothing's good for me, I'll just do it. So you just can't stop there. That's my point. Okay, next slide. All right, so I've drummed that into you. Okay, so let's talk about the types of incontinence. I break it down to 3. The first one is called stress incontinence. Stress means when you cough, you laugh, you sneeze, you bend over, you reach up, you do something that causes an increase in the pressure in your abdomen, and that gets transmitted to the bladder. And if you don't have the proper support, you'll leak. So if I do this and I leak, I have stress incontinence. Okay. Now it could be something that occurs occasionally if you're laughing real hard, and everybody has that maybe once in a while. That's not really a problem. But if it's something that occurs every day and it keeps people like, pickleball is the big new craze, and I can tell you my office explodes sometimes with people that are incontinent now because they're playing pickleball. They never had a problem before they played pickleball because they weren't stressing it. And now they're playing pickleball and they're jumping and running, they're urinating. So pickleball's been a really good thing for this. Okay, so stress incontinence is the most common type of problem. It's actually more common in younger women. Women that have babies, they're in their 40s, and things start to break down. And it is so easily treatable. That I would urge anybody that has that problem to not hesitate to be evaluated. Now, urgency incontinence gets a little bit trickier. Urgency incontinence means you get an urge to go to the bathroom and you can't make it. Okay, you can't make it there. You start to go and your bladder starts contracting, and before you can get your pants down and sit down, the urine's starting to come out. And that is a complicated situation because, again, that has to do with, sometimes it has to do with the brain. I'm going to tell you something. How many people would think that when they get home, they didn't have to urinate, they're in the car, they get out of the car, they put their key in the door, and oh my God, they got to run. You didn't have to go 5 seconds ago, but now you got to run there, and if you don't get there, you may lose it. That's urgency. That's something that is called a conditioned response. It was well established. How many people remember Pavlov's dogs? So with Pavlov's dogs, remember, He rang a bell, and then he gave the dogs a piece of steak. Pretty soon, the dogs, upon ringing the bell, would begin to salivate. It's the same thing with people. They get into a situation where something that they normally do is followed by going to the bathroom. And pretty soon, just putting the key in the door, or walking by a bathroom, or turning water on, or thinking about going to the bathroom, starts causing the bladder to contract before they get there. And that contraction builds pressure up so great that oftentimes the sphincter can't hold it in. And what the problem with that is that before people come to the doctor, they try to treat that by what? By just saying, oh, well, I'll just go to the bathroom more frequently. Well, guess what? When you go to the bathroom more frequently, you are teaching your bladder to tell you that it's full sooner and sooner and sooner. And pretty soon, you're having to go to the bathroom every hour, and there's not that much there when you got to go. That's why that is such a counterproductive activity to do. And you if you train your bladder that way, we have to untrain it. And how do you know if you have that issue? Well, there's people that tell me that they have to go every hour, hour and a half during the day, but they'll sleep through the night. Well, what does that tell you? Their bladder capacity is normal. It's just when they're awake and they're conscious, their brain is controlling their bladder in a way that they can't control. So that problem is a little bit more involved in undoing. And it requires oftentimes therapy, oftentimes medication, sometimes both. It really is not a surgical issue. It's a behavioral issue, and it's a sometimes medication issue. Well, oftentimes, we can treat some of these things, and as soon as we educate women about how to actually go about their day, we can eventually get people off medication, because our goal here is we really don't want to use medication if we can at all avoid it. We have a whole therapy program, which I'll explain to you. And our goal is to avoid medication and certainly surgery. And then there's mixed incontinence. Mixed incontinence is mixed, both. You got everything. You're losing it when you cough and sneeze. You can't get to the bathroom. I mean, it's a mess. And that's difficult to address. And a lot of times we have to address each issue separately. And we decide on which one's worse and what needs to be addressed. And then the least common but most impossible thing to treat is overflow. And what that is that when you live a life of just holding your bladder, teachers, nurses, flight attendants, they get used to, they brag, when they're younger, they're a camel, they can hold, their bladders can go for 8 to 10 hours. Well, what they've done in those years is they've stretched their bladder out so much that muscle that's supposed to contract, it's so stretched out that when it contracts, it just doesn't do much. And so the bladder becomes just a flaccid bag. And what happens is it doesn't empty when it's supposed to, and you have incontinence because it's overflow. And that is a much more difficult thing to treat. Most of the time when I see overflow incontinence, it's more what we call iatrogenic, or it's from something that keeps a woman from being able to urinate properly, and her bladder just keeps, whether it's uterine fibroids or some other problem inside their pelvis, and they can't empty. There's obstruction to voiding, and then their bladder gets so filled, and then they wind up in the emergency room, and someone puts a catheter in, and there's a liter of urine in there. Imagine a liter. Okay, well, that does a lot of damage to the bladder muscle. Okay, next slide. All right, so those are the problems. Now, when we evaluate people, we want to listen carefully to their history, because the history to me is the most important. And then we want to do a physical exam. We want to make sure, is there a prolapse? Prolapse means things are starting to fall. You've heard of a dropped bladder, almost everyone has. Well, that's what a prolapse is. Or a dropped uterus. certainly if those things are present, that creates a problem with emptying the bladder. It creates a problem with incontinence. So we have to make sure that's not an issue. And then oftentimes, if it's not straightforward based on the history in the exam, we have a test that we call urodynamics. Urodynamics is a test that's designed to tell us more in-depth information about what's going on inside the bladder. How much does the bladder hold? What kind of pressure is necessary to get past the sphincter? Is there stress incontinence? We have you cough. We can see if urine leaks out. We measure the strength, the integrity of the nervous system in the bladder, so we can tell if the bladder is contracting on its own. It gives us a wealth of information, and then we can take that information, the context of the exam and the history, and then come up with the right diagnosis. So again, it's not just here, take this pill and see if it works. It's not that. Thanks. So, okay, we've discussed the problems, the investigatory methods that we have, and now we talk about treatment. And I really just want to say a little bit about these things, and then leave it open and then talk about physical therapy. So first, one of the big misconceptions is that when I first started in my career back in the 80s, surgery was a big deal. There wasn't these outpatient, minimally invasive procedures. We did surgery only on the most incontinent women. We had 65% success rates. And most of the time, women had to stay in the hospital for 4 to 6 days, and they had to be on their backs for 6 weeks. So you can understand why somebody would live with a lot before they would go through that. Well, over the years, that has completely changed. It has become an incredibly minimally invasive thing to treat most kinds of incontinence. The most common thing that we do for stress incontinence is what's called a sling. A sling is just literally, I'm not kidding you, it's a 20-minute outpatient procedure with a 2-day recovery period. And after that, people go back to work, go back to driving. We tell them we don't want them to lift heavy things or do any heavy exercise or have intercourse for 6 weeks, but they can certainly do everything else in their life. And it has probably close to 95, 97% success rate. So it is something that has become the gold standard of treatment for stress incontinence. It lasts forever because it involves a permanent piece of tape that's put in there. And that tape is a mesh. Okay, now, when I say mesh, I was like, nope, cut me out. But mesh is not the mesh that you heard about for all those years. Those meshes are off the market. The meshes that we're using now have been studied. I personally have put over 2,500 of them. And I've never once, knock on a wall, that had a problem where it's eroded or grown into something that it shouldn't. And it is extremely successful in life. And so, those meshes are gone. I don't even know that the problem was honestly with the meshes. I think when all of this became, the rage, too many companies were out there pushing it with too many doctors. They really didn't have enough patients to get ever good at doing that. And it wasn't something that we were learning in residency. There was no fellowship training for it. So I think, it got a bad name because it was not being used properly. But now that the only people that are using it are those that have gone through proper training and have a volume that supports it, we really don't see those issues. Okay. The nice thing about the sling is that it does not have to be repeated. So women in their 40s that get it, they're going to have it through their whole life. 50 years after they're dead and gone, someone digs their bones up for some reason, they're going to find their bones, their teeth, and this sling. So it lasts forever. It doesn't have to be replaced. I mean, I think I can count on the fingers of 2 hands how many times I've put a sling in someone that's had one in the past. And the only reasons are sometimes someone gains 50 to 100 pounds, or someone develops some COPD where they're constantly coughing, severe constipation, maybe. But otherwise, it's a tried and true procedure. It's not worth putting on. Okay. So the other types of surgeries that we have to do sometimes are surgeries that correct pelvic organ prolapse. I'm going to show you a slide in the future about what that is. But again, those are minimally invasive vaginal outpatient procedures that don't really have a lot of discomfort associated with them, and certainly a very, very abbreviated recovery period. So this here is the sling I was talking about. This is the bladder, and this is the urethra. Okay. We make a tiny incision inside the vagina that's about 2 centimeters. And then we can slide this sling in under the urethra. But what happens is, if this is the sling and this is my finger is the urethra, after it grows into your tissues, it supports from the sides and from below, like a sling. And when you cough or jump, the urethra doesn't move. It's just simple physics. And it's very effective. Okay, so why does this happen? Why does this happen to women as they get older? Why does, they had babies 30 years ago, so they were fine until, they hit menopause. And then all of a sudden, they have problems with their bladder and they have problems with prolapse. And a lot of that has to do with the levels of estrogen. Estrogen, is when estrogen runs low, the bladder, the vagina over the rectum, as well as under the bladder, those support structures weaken and give way. In addition, there's gravity. You've got 20 more years of just being upright, and that gravity, and let's face it, women today are way more active and way more demanding on their bodies than perhaps they were 30 years ago. So that is why we start to see those problems, those cumulative effects of gravity, of menopause that result in decreasing tone and muscle strength. And that's why we have the problems as we get older. So when we talk about risk factors for pelvic organ prolapse, that's the prolapse of the uterus or the bladder. We talk about chronic problems, obesity, chronic coughing. Smokers were big people that, big problems a lot of times because they're coughing so much and it's just that much more force on their bladders. People that have chronic constipation with irritable bowel syndrome have oftentimes developed prolapse issues. Okay. People that have had hysterectomies. The way not so much anymore, because we've learned that we do hysterectomies differently now, and we support the structures so that doesn't happen. But if you had a hysterectomy done in the 80s, it wasn't done in a way that would support the bladder in the future. So a lot of times you'll see women that have had hysterectomies have more problems with prolapse. And then people that have what we call connective tissue defects. Those are more genetic things. Your mother had prolapse, your sister had prolapse, now you have it. Well, that's genetic. It has to just do with your own support structures. Next. This is the number one thing. These babies come out and they love you to death, and you take care of them. You take care of them for 30 years, and then you got a problem, and guess what? It's because of them. Because there's just no way to have a vaginal delivery without traumatizing the pelvic floor. And oftentimes these muscles can compensate for the damage that's done as that baby comes out until you lose the estrogen, or until you gain 20 pounds, or until you're just the effects of being on your feet for 21 years. So certainly women that have had no children or no vaginal deliveries have less of an incidence of incontinence issues than women that have had babies vaginally. So I was just going to put this in here to show you what prolapse is. So this is the normal situation. You've got the vagina here, and above the vagina is the bladder. And this yellow tissue here is connective tissue. That's what keeps the bladder out of the vagina, encroaching on the vaginal space. Here we have also yellow tissue, connective tissue that keeps the rectum separate from the bladder. So in the case of the bladder, you see this is the bladder, this is the urethra, and you see how there's a straight shot out. The bladder contracts, urine comes out. Same thing with the rectum. Stool comes down, follows the path of least resistance and out of your body. Now, if you have a cystocele, you can see what's happening here in this slide. See how the bladder is dropped into the vagina? And now the urethra has got a kink in it. See? So symptoms of that, if you're wondering, well, do I have that? One of the things that you can ask yourself is, do you have a problem emptying your bladder? If you're sitting down in the toilet and it's just kind of slowly coming out, or you have to kind of rearrange yourself all the time, or lean back, or even you stand up, go wash your hands, and you got to go again. Okay, that likely is because you've got two pockets in the bladder, and you stand up, and then the other pocket goes, the urine that's in that pocket goes into the one that's now available, and you got to go again. So that is symptomatic and suggestive of what's called a cystocele, or a bladder that's herniated into the vaginal space. And I don't have a picture of it here, but the same as the rectum. If you can imagine the rectum prolapsing into this space, stool comes down, and instead of following the path of resistance out, it can get stuck in a pocket. How do you know if you have this? If you're sitting down, you have a bowel movement, the stool is there, it just doesn't come out. Or you have to rock yourself back and forth to get it to come out, or you have to put your fingers down by your vagina and actually help push it out. That is what's called a rectocele. Nobody volunteers that information unless I ask. And then, if that's an issue, that is a symptom that's easily corrected of what's called a rectocele, or a hernia that's occurring between the rectal space and the vagina. Okay. All right, medications. Now, you can't turn on the TV these days without seeing somebody, who's incontinence, and they're talking, all the medications are out there. And, the medications that we have started with this. This is what's called oxybutyn. That's been around since the 50s. And it's a good drug for treating the people that have urgency. If you have stress incontinence and you take this drug, it doesn't work. Okay. It's only for urgency and frequency. Okay. The drug works on the receptors in that muscle that I showed you that contracts, and it tries to block them so that they don't contract as often. The problem with ditropan, or oxybutyn, is that there are similar receptors like that all over the body, and it's not selective for the bladder. So oftentimes the side effects associated with that medication are just worse than the urinary. People will say, I have dry mouth, I constantly have to drink, and the more I drink, I'm losing urine. What am I doing? And the same thing with, it causes constipation, because it blocks the peristalsis of the colon. So you got to pick your poison with those drugs. Now, since that time, we have developed drugs like Vesicare and Enablex and Sanctura that are more selective for those receptors that are just in the bladder. So it has a better side effect profile. The problem is that Medicare always wants everyone to be on this. It just hasn't caught up, and these drugs are not covered oftentimes by Medicare, even though they're better drugs. This one in particular, Sanctura, works a little differently, and especially in older women, it doesn't cause the side effect of altered mental, because it doesn't cross the blood-brain barrier. It works slightly differently. So, it doesn't cause confusion. If someone has a little bit of memory issue, or if someone has, just the signs of early dementia, I certainly wouldn't want to put them on one of these drugs. But this one I would. But oftentimes I get pushback from Medicare. So, it's a battle. But it does work the same way. And then we've got these are the newer drugs, Mirbetriq and Gemtesa. I think these are the best drugs. They work without really any side effect profile. They work quickly and they're well tolerated. The problem is insurance. Insurance is, especially with, a lot of them won't cover. I think Medicare now covers the Gemtesa. I can't get Medicare to pay for the Mirbetriq, so we have to play with it. We have to write all kinds of notes a lot of times. And fortunately, these drug companies, because they make so much money, they give us samples. So before I decide to fight a battle for a patient, I give them a month of samples just to see if it's even worth fighting. But if they work, they are very successful in treating urgency and frequency, not stress. There really are no good medications for stress. Okay, next slide.
May I ask a question?
How many? Yeah.
Wanted to go back to the surgery. And what's the oldest that you recommend someone for surgery? Like my mom is 86.
Well, it depends what she has, but and what her other medical problems are. But honestly, I've done surgery on 90 plus. It depends. Age is a number. There are 90-year-olds that would not hesitate to operate, and there are 75-year-olds that wouldn't. So it really depends on what their other conditions are. So I try not to put an age down. We're going to talk questions in this
All right.
at the end. I'm going to give you all a chance. Now, Botox is another thing that has become very popular in treating urgency incontinence. Botox is the same stuff that you put in your face. It works very well, and they're using it for migraines. They use it for trigeminal neuralgia. They use it all over the body. It's really the wonder drug of the millennium. And we found about 10 years ago that we can inject it in different places in the bladder, and it can have a profound effect in preventing that muscle from contracting. It's a literally 5-minute procedure in the office always. People come drive themselves, drive home. It's works very well for anywhere from 6 to 8 months. And then you do it again. And I think, you guys could bear me out, but probably at least one every time I'm in the office, we have one Botox. I mean, that's the average. It's very, very common. And usually if the medications are the first trial and the therapy doesn't work, then we go to Botox.
Insurance will cover that.
Yes, easily. And then finally, InterStim. InterStim is something that I don't do as much now because of Botox, because it's a little bit more invasive. It involves making an incision and putting a pacemaker into the hip underneath the fat pad of the hip here. And you have an electrode that dives down through the S3 foramen into the nerves, the sacral nerves here that control the bladder. And then there's a modem that, it's like works like a remote control, and you can control your bladder function much the way a pacemaker controls the heart. And they go in, it's like, it works. You do a test with it before you actually implant it, so that you're not going to get something implanted that we find doesn't work. So it's a whole process, but it's more invasive. It involves, let's face it, your generation isn't exactly computer savvy. You're learning cell phones, but this is more complicated in a lot of ways. And so there's more involvement with other people to try to help regulate the impulses. So I used to, before Botox, we were doing, 50 a year, and now we probably refer less than 1 or 2. But nevertheless, it is a treatment. Okay, pads. I hate them. That's like when I lose, that's the patient that we have to say, just use pads. I can't do anything. Pads is what we are, the anti-pad. Okay. There are other things on the market like this that are very effective, but they're expensive. This is a little very soft rubber patch called Impressa, that if everything else fails, it can actually be put on the urethra. It's just a patch that blocks urine from coming out. And then you sit down when you want to go, every 3 to 4 hours, you take it off, you pee and get another one. And, the problem with it is that they can be expensive. And it requires a certain amount of dexterity, obviously. Okay. And this, this is off. This is like for historical purposes. All right. So now I want to talk about something that I feel, is what defines us as opposed to anyone else that's treating incontinence or physical therapy. You've heard of physical therapy for the pelvic floor. And, I think a lot of places say, oh, yeah, we do this. But they don't do it the way that we do it, the way it was intended. The government came out with a recommendation that the first line of treatment should be behavioral intervention and therapy. In other words, teaching, you all know it by Kegels, right? Everyone's heard of Kegel exercise. So if I said to you, just go do Kegels, I guarantee most of you will not do them correctly. Okay. And I have no way of knowing if you're doing it correctly. How would I know? How do you know? How do we communicate? Well, that's what our therapy is designed to do. Okay. We'll come back to this. I don't know why I want to get to the therapy. So right. Okay. So we call it biofeedback because what we use is computers to try to teach you how to strengthen your bladder. So again, if I say to you, I want you to do this. I don't know if you're doing it. You don't know if you're doing it. What we do is we have a probe that you all would put in your own vaginas, and it gets connected to this computer, see? And then the therapist will work with you and they'll say, I want you to do this. And then she can see which muscles have been weakened. And she can see if you're doing the things that will correctly strengthen them. And you'll see a graph on the computer go up with what you're doing with your pelvic floor. That's how we know, okay, that's a Kegel and you're doing it correctly. No, that's not a Kegel. Look, your abdominal muscles are going up, not your vaginal. You got to use these muscles in the back, not in the front. That's how we can communicate and we can be sure that we're both on the same page. Then we tell you, okay, go home. We want you to do this 3 times a day. Then you'll come back next week. We'll put you back on and we can objectify. We can see, are you stronger? Or are you not? Is it working? And we do this for a period of maybe 5-6 weeks. And we can absolutely increase pelvic floor strength and make it so that people finally understand, how is the bladder supposed to work? And what am I doing that's making it worse? And we talk about time voiding. We talk about the fact that you need to intellectualize a little bit. You need to say, I got to go to the bathroom right now, but I don't really have to go. My bladder's not full. So rather than run to the bathroom while I'm pulling my pants down, I'm going to stop and I'm going to employ some of these techniques and I'm going to try to get that muscle to stop contracting so that I can go on and let the bladder flow. And as we do that, you retrain your bladder so that it accepts more and more liquid in there. And that's how we treat the problem. Okay. So in the beginning, I told you that, one of the worst things you can do, and I think we had a surge of this with COVID because everybody, even younger women, everybody's working at home and they walk by a bathroom every 10 minutes and they just gotta go. And all of a sudden they gotta go all the time because it's like, the bathroom's there, are you gonna use it? It's the wrong thing to do. So I understand life is life and you don't want to be caught in an embarrassing situation. So the better thing to do while you're trying to retrain your bladder is to say, I go to the bathroom right now. I feel it, but I'm leaving the house in an hour. So I'm going to wait and go closer to when I'm leaving and I'm only going to go once. Same thing when you're leaving wherever you're going. So, you're not running around the store looking at where that bathroom is. Hopefully you can eventually not have to be aware of it. With the therapy, it's once you get the hang of it, our therapist will tell you that it's something that's very easy to comply with, because if you don't continue with the exercises, then what happens? Right? You do go to the gym, you get yourself all in shape. It doesn't last unless you keep going, right? So the beauty of this, you don't have to put on an outfit. You don't have to go anywhere. You can put a sticker on the steering wheel in your car and say, every time I get to a red light, or not every time, 1 or twice during the day when I get to a red light, I'm going to Kegel. That's all you got to do. Just Kegel while you're at the red light. Okay. And you do that once a day in the way that we taught you how to do it. And a lot of women will find that they have much better control over their lives. Okay, let's go back to those. All right, let's do this one. All right, so here, again, before biofeedback, this kind of shows you, we ask a woman to do what she thinks is a Kegel. And this is the abdominal muscles. See how they're just like contracting like crazy? And the pelvic floor is very little. Well, after they've done biofeedback, the muscles in the abdomen stay quiet. And the pelvic floor muscles are what go up and they're strengthened. That's what I'm trying to explain to you, is that there's no way to do that without objective measurements of it. Okay. Back the pessaries. Okay, I just want to spend a little bit of the time with this. These are pessaries. Anybody heard of that? Okay. So pessaries are things that we can use. You can see, we have a whole closet. They come in different shapes, sizes. They all do different things. But the idea behind a pessary is that someone who isn't a candidate for surgery, like maybe, the 90-year-old that we talked about, we can oftentimes comfortably put something in the vagina that will hold everything up and will recreate the normal anatomy and the relationships between the bladder, the urethra, the vagina. And a lot of times, if that's successful, then we have a lot of women that would come in every 3 to 6 months. We'll take the pessary out, clean it, put it back, and just let it be. Okay. I don't think it's a great option for younger women. But I think for women that either are non-candidates for surgery or don't want surgery, it's an option. Okay. All right. Yeah, we went through all this. Okay, so now the other thing is food and drinks. What you put into your body definitely has an effect on your bladder. Things like orange juice, any citrus fruit drink, caffeine, coffee. You drink 2-3 cups of coffee, I can't help it. It's gonna make you, it's a diuretic and it's a bladder irritant. So, you got to pick your poison. If you really have to drink your coffee in the morning, you're gonna go to the bathroom a lot. It's just, you can mix it with decaf or you can avoid the caffeine somehow. But people that drink, a lot of Diet Cokes, that's a problem. So caffeine is the number one thing. Citrus fruit drinks, tomato juice, alcohol, terrible. You want to go out to dinner and then out to a movie. I don't know if people do that anymore, and you're going to have a big pasta dinner with red sauce and a couple glasses of wine. You're not making it through that movie. Okay, so you got to think a little bit about what you're eating, what you're drinking, and what effect it may have. So again, the bladder control myths, okay? It's not an inevitable event of getting older. It is a common event, and it is a treatable event. It is not something that you have to accept. You should seek treatment. And if you know people that other people, if they're having a bladder problem, get help early. It's easier to treat the earlier we intervene. it's an inevitable consequence of childbirth. It's not an inevitable, but childbirth does make it more likely that it will happen. I mean, we have nuns that have incontinence. They haven't had sex and they haven't had children, but they have incontinence. Next one. All right, my last sign is the red light. This is where you should kegel. So, you know, you get to a red light and someone is a little bit late, going, don't honk them because they're kegeling. All right, so this is, I'll put this, hello, kind of. So now we can take questions. Who has a question?
Why does it happen at night? You have to go through the pipes at night.
Well, again, that's a loaded question. It may happen during the night because during the day you aren't urinating. You know, it gets complicated. You know, if you're the first question I ask when someone tells me they have to get up 2 or 3 or 4 times a night, I say, well, when you get up, is there a lot of urine? Because if there's a lot of urine, it's not a bladder problem. If the bladder's full, you got to empty it. The alternative is to pee in your bed. What we have to do is we have to say, well, why does she have so much urine at night and not during the day? And a lot of times it has to do with cardiology. In other words, your heart, when you lay down, you're flat, your heart is more efficient, and all of a sudden your kidneys are bathed and you start making a lot of urine. We need to talk with your internist or your cardiologist about using medications that will make your heart more efficient during the day so that you maybe don't have to urinate as much at night. So that's one issue. The other issue is people take all kinds of medications to help sleep. Okay. And, you know, if someone will tell me, you know, I don't have a problem during the day, but at night I wake up, I have to wear pads, I'm socked. I can't make it to the bathroom. Well, when do you go to bed? 10 o'clock. When do you get up for the day? 7. I go, so that's 9 hours. And you think you're not going to go to the bathroom in 9 hours. Why don't you just set your alarm and get up and go? Because your bladder's not made to go 9 hours. So if you're taking something, whether it's an antidepressant or any other medication, and you're a sound sleeper, so you're missing the cues that your bladder's giving you, then you have to, again, take control of that by setting your clock. It's a loaded, there's not one answer, but it needs to be investigated. Anybody else?
I had a question about medication. So definitely any medication that you could take, you can simply evaluate by a urologist, ideally, right?
Well, not a urologist. We are either a urologist, a urogynecologist, or a gynecologist, you know, someone that does this. You know, oftentimes the urologists aren't really the people to go to for this because they're more surgeons, they're surgery oriented. You know, they don't have these therapy programs. And, you know, I think nowadays, you know, there are more dedicated centers like ours that are just treating people with incontinence.
And another question, doctor, I had was the procedure for this thing, that required general anesthesia.
No. Most commonly we use general anesthetic, but we use a short acting, you know, 20-minute. It's a 20-minute procedure. It can be done under spinal. The important thing is you can't move because we're working very close to, you know, the bladder, the bowel. We don't want to have a sudden movement and then all of a sudden we're in something we don't want. But it's short acting. I mean, most patients are out of the outpatient center within an hour.
Should you stop drinking liquid at a certain time, like at night, you know, right? Or last night,
Yeah, I mean, I think if you don't, I think that as long as you're drinking enough during the day, you know, you can cut it off around 7 o'clock. But if you're drinking a lot, you know, right before you go to bed, you could have to, you know, right.
you know, this might have to be your area of expertise, but some of these things apply to men as well.
Yeah.
Like frequently going to the bathroom.
Well, but yes, they have the problem, but the mechanism is different. You know, men have prostates. And the prostate is oftentimes the culprit when it comes to bladder function. And that's a whole different set of medications. So men need to be evaluated by urologists. But I'm a man and I have a prostate, so I can tell you it's.
Yeah, but I was, you know, it's like the notion of I'm leaving my room. I haven't been, I've never heard of it. I'm leaving my room, so I better go to the bathroom now. 'Cause I don't want to have to go, and then
Don't do
and
it.
I'm trying to discourage it.
Yes, that is the same. We train our bladders the same way everyone else does.
All right, before I came in here, I thought I had to go, but I didn't. And this happens sometimes, and other times, especially if I've been distracted or moving. And then I go and it's like it takes a minute, like empty sound. So I don't, why do you get that feeling as you're older? And I think I have to go because I'm going to go somewhere.
It's exactly what you're making my point. Because of the brain, that your brain is telling you, you know what, I'm going into this talk right now. This guy's a long-winded guy. He might be, I don't want to have to leave in the middle of it, so I better go, even though I don't have to go. So your brain is telling you have to. You get in there, there's not that much there.
No. You just sit there for 10 minutes.
Don't sit there for 10 minutes. Don't push. Don't push.
I know.
People sometimes ask me, well, how do I know if it's a slower strain? Well, one way you can know is when you go to a public bathroom and you're sitting next to somebody in the next stall, you hear them, and you're going, you started before they got in there, they're done before you're done, you've got a problem. So you can listen to external cues. Okay, anyone else? Yes.
And you were talking about this thing, that's what you call surgery now, and is that the same as a pessary that was removed?
Well, the idea that it's not the same as the pessary, the ultimate result is the same. We're trying to use the pessary to occlude the urethra, but it's just it doesn't work nearly as efficiently or as well as a sling does.
Should we try it first? Or?
No, I think that I would not encourage a pessary for anyone unless there was really a contraindication or a hesitancy to do a simple surgery. It's not something that I think that, you try a pessary and you live with it. Ultimately, if you live long enough, someone else is going to have to be helping take care of you. And that's just not an easy thing to do. And that's what happened.
Do you do everything in the office?
Yeah, well, the slings are done in the outpatient. At Northwest Community in the outpatient. Northwest Community.
An insurance question, it's covered by
Yes.
Medicare.
Yes.
In the winter, when I go outside and it's really cold.
Yeah.
Start walking, all of a sudden, what kind of incontinence is that?
Urges. Again, that's just stimulating those receptors to.
What about when the water's running? I mean, I know the tea kettle.
Right, and if you did it if somebody else was doing it, you didn't hear the water because you had earphones in, you wouldn't have to go. That's Pavlov. That's the condition. Yeah, don't do that to that's true. Others always were telling you, we're leaving the house, go to the bathroom. Yeah. Yeah. I think pretty much. Well, I don't know. Honestly, I don't think there's a program like ours at like some of the other hospitals, but they do the surgery. There's people that do the surgery. It's a common surgery.
Yeah.
Millions are done.
Would you do a consult first?
Well, yes. I don't just, yeah. Yeah. Yes,
What is the medicine that they have to be using?
the Mirbetric or the Gemtesa, Gemtesa, Tesa. That one's better covered with Medicare. MYRBETRIC.
I'm trying to.
Yeah. Are we,
I think it's about time, yeah.
Anal exercises help men also?
yes, yes, helpful. Okay, estrogen helps. A lot of times, not progesterone, but you can't, a lot of women can't take, if you don't have symptoms of hot flashes or night sweats, then you don't need oral estrogen. A lot of times you can just use vaginal estrogen. And vaginal estrogen is not absorbed systemically, so there's absolutely no risk for that. You can use a patch, but if you have a uterus, then you have to have both estrogen and progesterone.